Ciao mondo, hello world, hola mundo, hello monde. We're here today in the International Renal Research Institute of Vicenza taking a cappuccino with you and discussing about contrast-induced AKI. Acute kidney injury may occur indeed after injection of iodinated contrast media for interventional cardiology or radiology imaging techniques. At this point, this is extremely important syndrome because it may indicate that the patients may undergo worse outcomes, may also the patient have increased cost for the society, but especially most of everything, increased number of complications, including higher mortality. At this point, cardiologists and radiologists should be aware of the risk of developing an insult and an injury to the kidney when injecting iodinated contrast media. And there is an increasing body of evidence that shows that using isosmotic, isoosmolar, non-ionic contrast media compared to high osmotic contrast media may have an impact on outcome and different measures of results, including comorbidities and mortality as well. The important aspect is that the nephrologist should be able to help to characterize the patient and identify patient at risk to develop contrast-induced AKI, especially using most modern biomarkers, for example, IGF-BP7 and TIM2, the so-called nephrocheck, but also other biomarkers including NGAL or cystatin C. The use of creatinine can be actually also be important in detecting increasing serum creatinine after contrast-induced complication, but also it may be used to detect an initial stage of chronic kidney disease. Nevertheless, today we know very well that even though creatinine does not increase after an injection of contrast medium, the insult to the kidney may be present and acute kidney injury may be subclinical. It is normally identified in this case by a rise in biomarkers both in urine and serum, while creatinine may stay normal. Another important issue is that patients that develop AKI may lose up to 50% of the nephrons without having any result in creatinine, without having any change in serum creatinine. Thus, this patient may result into a condition of maladaptive repair after AKI and progressing towards chronic kidney disease with fibrosis and altered renal mass. If this is the case, you may not see immediate consequences of the injury, but in the long term, this patient may have complications, including chronic kidney disease. Thus, today is not just important to prevent AKI, but also to manage the patient who had AKI recently or is in the recovery phase to avoid a superimposed injury to the kidney that is already suffering from an acute injury, and also preventing progression towards chronic kidney disease and any conditions that may favor fibrosis in the renal tissue. To improve awareness and alertness about this problem, we have put together in Rome recently a group of experts from Spain, Germany, and other countries, including Brazil and other European countries, that have discussed how the nephrologist can actually team with cardiologists and radiologists to make available in the hospital a task force to avoid and prevent contrast-induced AKI, and also to protect the kidney once AKI has developed. I think that the important task has been accomplished to develop a slide deck, which is an educational tool to increase awareness about this important syndrome and the effects of contrast-induced AKI. We're also planning to write a white paper to improve awareness around the world about this syndrome, and possibly and potentially to develop strategies to prevent AKI, but also to protect the kidney when the injection of contrast media is necessary for diagnostic imaging techniques. In this case, the use of small doses of contrast media, but also the use of less toxic and less vasoconstricting agents, including, for example, udixanol instead of Uxol or other contrast media which are at high osmotic power, may indeed make the difference. Probably, and a study has been done recently, the higher cost of this contrast media may be counterbalanced by the reduced number of complications and by the lower mortality in these patients, thus paying very much for the difference and showing a benefit from the cost-benefit point of view. Health technology assessment today is mandatory when any type of new device or drug is utilized in clinical practice. Health technology assessment has been made for isosmotic contrast media and have displayed the important benefit of this media for the patient. At this point, I thank you very much for joining today Cappuccino. I invite you to ask for the slide deck educational on contrast-induced AKI that very soon we will also place in the website of our institute, and also we will invite you to read the white paper that very soon will be ready and probably published in one of the major journals of cardiology, of radiology. Thank you very much.